now have the pleasure of introducing Dr. Melanie Noel. She's an associate professor of clinical psychology at the University of Calgary and a full member of the Alberta Children's Hospital Research Institute and the Hotchkiss Brain Institute. She directs the Alberta Children's Pain Research Lab within the Vi Riddell Pain and Rehabilitation Center at the Alberta Children's Hospital in Canada. So her expertise on children's memories for pain and co-occurring mental health issues in pediatric chronic pain, that's what her expertise is in. She's published guiding conceptual models on children's pain memory development, co-occurring PTSD and chronic pain, fear avoidance. There's two of me. And and she can share even more about all of her accomplishments. And I would just like to also say, her talks here at the San Diego Pain Summit has made things like children's immunizations for Ollie so much easier. If you've ever wanted to see nociception and pain and how they're actually kind of separate, and the encouragement to stay calm and understand as a parent or a clinician, our reactions to people's pains matter. So I've learned so much already. I cannot wait to learn more. So here's Dr. Melanie Noel.
Thanks, Sarah. Hello, everybody. It's 5 o'clock and you're missing the sunset. No pressure. This has to be amazing, and I hope it is. I've been thinking about this for weeks. I'm so excited to be here. Rajam, I know she's out there. I came here 2 years ago, right before the pandemic. Remember that? Who was there? Hands up. It was amazing and magical, and I was like, what's going on? The fire pit, and I was like, this is such a quirky, cool, magical community, and I've made so many friends. Joletta, I'm looking at you. Keith Meldrum, Richard, Rajam. I love this meeting, and I love talking to all of you. So thank you for having me. I'm so excited. But I am a psychologist. Any psychologists in the room? I'm the lone psychologist. And you know what? I don't feel like an outlier. I feel like I fit in with you guys. So thank you for embracing me. I actually think a lot of the magic happens with physical therapy and manual therapy, right? When you're actually getting people to move. That's when you evoke emotion, right? And memories and things like that. So last year I talked about trauma. The year before I talked about memory. But today I'm really excited to talk about a phenomenon that I think is super crucial to the experience of living with idiopathic or primary chronic pain, and that's diagnostic uncertainty. So I'm going to be a little bit vulnerable now, inspired by the people with lived experience and the fierce advocates that I work with. All of my research is partnered. I've been kind of tuning into my own lived experience. And this is why I got interested in this topic. So I was doing a postdoc in Seattle at Seattle Children's Research Institute, and I got pregnant with triplets. It was a very surprising, unexpected, sort of scary experience. And I was researching chronic pain. So I was studying, the experience of parents who have a child with primary pain conditions. So how many of you work with kids? Okay, so 3 people. I know, right? Welcome to pain conferences. We're like outliers. But the adults you work with were kids. And 60% of kids who have chronic pain become adults with chronic pain. A lot of this starts at puberty, right? So I was interviewing these parents, and I was kind of becoming a parent myself. And my child, Jasper, was born with a rare interstitial lung disease. And at about 6 months of age, he had trouble breathing. And it was really scary, because his oxygen would drop. He had tachypnea, he was breathing really fast. We were in and out of the hospital. We had test after test after test. Negative, 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 negative. I should be happy, right? It's not reflux. It's not cancer. It's not this. It's not that. And those test results provided no relief. They fueled my worry that it was something more sinister going on and causing him the inability to breathe. And I hung on to every word that the clinician said, right? Especially when his functioning was bad. When his functioning was bad and he couldn't breathe, that's when I really thought it was really sinister, right? And I still remember a nurse, after years after getting that diagnosis, I'm happy to say he's doing great now. He's got ADHD, but hey, Vyvanse is great. Medicine is great. He's doing great. So it's easier for me to buy into this diagnosis, but he never got the biopsy, he never had the scan, he never had the test to prove that it was knee high. You've never heard of it, neither does his pediatricians. It's rare. And I thought to myself, what torture is this when you have a health condition that you can't prove what the cause is? And this is chronic pain. This is primary pain conditions, right? And I was interviewing these parents, and I'll never forget interviewing this mom. And, I asked her, what's this been like for you? And she would burst into tears. No one asks the caregiver what their experience is, right? And I gave her an opportunity to narrate her origin story, her experience. And she looked at me and she said, I wish it was cancer. And it took me years. In fact, preparing for this talk, I finally got it. But I thought, how could a mother wish for a life-threatening condition when you can have chronic pain and you can learn how to function and you can do CBT and you can work on your sleep and it's all rainbows and puppies and all of the things? What that mother was saying is the torture of not knowing and thinking that something more sinister is happening and causing the pain that the doctors haven't yet found is a form of torture. And that's what she meant. So what is diagnostic uncertainty? Does this ring a bell to anyone? I'm sure many of you are clinicians, right? This is the definition. So it's the subjective perception. So you believe that there's an inability to provide an accurate, a correct explanation for your health problem. Okay? So it's the belief that the diagnosis is incorrect and the explanation is incorrect. Okay? This is so crucial. Tamar Pincus, has anyone heard of her? I know Tasha has. I know Joletta Cool. She's an amazing psychologist. She's really into acceptance commitment therapy. And Tamar and Daniela wrote this beautiful, heart-wrenching paper called Chasing the Ghosts. And they interviewed adults who had non-specific, I'm using air quotes, okay? Non-specific low back pain, and interviewed them like, what's this like to have this diagnosis? This diagnosis, is it a diagnosis? And these individuals were just like the mom who wished it was cancer. They felt so much guilt that they couldn't legitimize their pain, right? There was so much social stigma. I mean, talk to people with lived experience. I'm sorry to look at you, Joletta, but when I heard you and Keith talk about the invalidation and the stigma from provider to provider, I still remember Keith telling me he had pain since he was 16, and it took him till he was 30 for someone to say, I believe you. 30. I got chills just thinking that. And that was at the San Diego Pain Summit. Oh, powerful. So they talked about chasing the ghost. It's this unrelenting search for a legitimate reason for your pain. What is a ghost? To borrow from my friend Abby Jordan, she's the most beautiful writer, beautiful person, and she collaborates with me on this. A ghost is transient, but always there. Seen by some, but not all. And this sort of haunted by something missing. Sure, there's kids and parents who say great, they go to the tertiary pain clinic after years. I mean, these are children. By the time we see them, they've been through the ringer. They've seen about 20 to 30 professionals. You know this, right? You're on the journey. And everything you say to your patient and your client or person with lived experience, they hang on to that, right? Just like I hung on to the words of nurses who, when Jasper was really suffering, she said, and I had bought into the diagnosis, but he was getting sick again. We moved to Calgary. It was like he was just getting sick again. He couldn't breathe. And the nurse said, are they sure that's what it is? uncertain again, after years of certainty, chasing the ghosts. This is really important. So we ask, it's not all doom and gloom, guys. There's power in our language. I know it's heavy content, though, and it's controversial. Are there any physicians here? Thank God. I know that's recorded. I like physicians. I do. But some of this is controversial. So this paper I wrote in Seattle, characterizing the pain narratives, the mom who said she wished it was cancer was in that study. And I was going through this experience with my son, and I was fascinated by, their stories, their narrative. Richard, you were talking about narratives, right? Patients come in with an origin story. They already have hypotheses about what's happening. Do you ask them about it? Do physicians? Where's the pain? Is it hurting? Is it this? Is it that? I mean, I have sat through tertiary pain clinic interviews and just my skin is crawling. This is not popular. I may lose some collaborators after this talk. Right? It's just this, but physicians are taught to do this. There's a symptom, there's a cause, there's a cure. Cut it out, change it, remove it, talk about the pain, not the holistic life of living with pain. And it's funny, I'm a clinician. I don't do clinical work anymore. I'm a researcher and I have 3 kids and I just don't have time. But, they come in with their narratives and their stories and their origin stories and a whole life. And I'm telling you, I am drinking the Kool-Aid, I'm a chronic pain researcher. I can tell you all about it. Does anyone really know why chronic pain develops? Raise your hand if you have the golden answer. Oh, right, because we don't know. We don't know the etiology. So what are we doing with our patients when we see them? We're doing this dance and pretending we are confident, but we're not. So we asked parents of kids with chronic pain. We got them to tell their stories. And I had my son at the time, and he was going through this thing, and I was sort of having diagnostic uncertainty myself. And I got really interested in diagnostic orientation. So that's the person living with pain, what they believe the cause is. Do they buy into the diagnosis? Are they still grieving? Are they still searching? That's unresolved, right? And we found that 40% of these parents, and these parents were in intensive rehab, okay? So this is I hate to call it end of the line, but this is sort of they've been through so many treatments already. 40% were unresolved about that diagnosis. They didn't buy in. So move your body and think differently. I'm a psychologist, right? Change your maladaptive cognitions. No, because it's cancer and the doctor hasn't done the 50th scan to find it out. And what I'm trying to tell you is that I really believe this is fundamental to the experience of almost half of people who live with primary pain conditions. And they're just not going to buy into our treatments if they're still searching and they're still chasing the ghost. So Tamara and I, in a bar in Bath, I know, poor me, I got a fellowship to kind of go over there and think about this. And I thought, we were going to talk about her cognition stuff. And I thought, oh my God, I was going through this myself, right, with my kid. And I was like, this diagnostic uncertainty work, it's got to be so relevant because we had heard this. We had heard parents tell us that they just needed a reason, that they were shopping. And they're shameful about shopping around because there's judgment about going to the acupuncturist and going to, right? Right? And they can be abandoned by the medical system. There are power structures at play, right? And we said, we got to uncover this phenomenon in kids. No one had looked at it. So it was really exciting. Now, I want to just really amplify someone who's going to be walking this stage in a few years. Her name's Alex Neville. She is a brilliant woman. She has spearheaded all of this work. And when I read her writing, it's like poetry and I can cry. It's beautiful. And so I really want to give her credit that so many of this, like her ideas are here, okay? So I'm the messenger, right? I'm the mentor. So we asked parents, so I want you to think about your own patients or clients. What do you ask them when they walk in the room? This seems really simple, but I actually think these questions, I didn't come up with them so I can say they're brilliant. I actually think it is. I asked you this. Where did it all start? Mike Osborne came up with that question. He wrote some beautiful papers on chronic pain. Where did it all start? This is a fascinating question because it gets at the patient or the client or the person with lived experience. It gets at their origin story. And I'm telling you, it's fascinating by how people think about your own whatever you got going on. Hey, 1 in 5 have a mental health problem, so join the club. Whatever you got going on, what if I asked you, where did it all start? Some parents go back to like in utero, okay? So they have like a 16-year-old kid with migraines and they're talking about their pregnancy. Other people will talk about yesterday. It's really fascinating. Where did it all start? Where are you now on your journey? So where are you at now? Where do you see this going? Very important. We don't talk enough about prognostic uncertainty. Am I going to get better? What does this mean for my life? Anyone who works in pediatrics, I've diagnosed kids with like ASD, autism spectrum disorder, and the kid is 5, and the parent's like, what the hell is going to happen when that kid turns 25, right? Where's it all going? That can stop people short. I really think these questions are rad. What do you remember about getting a diagnosis? What do you make of that diagnosis? How simple is this, right? And not many people are asking these questions. Those 4 questions led to hours of narration from parents and kids. They want to be listened to. Joletta, I'm looking at you, right? People want to be listened to and validated. And validation is my next big research endeavor, okay? I think it's everything. Okay, so we asked this. So what is diagnostic uncertainty? What is the phenomenon? Okay, what drives it? It's not just like, I think something else is going on. What drives it? So these are kids, they're like around the age of like 14. They've been living with pain for years. Lauren's mother says, they said chronic regional pain syndrome. A whole bunch of words that really tell us nothing. Now, and I'm telling you, it's so important. I think a lot about power. Like I'm thinking a lot about like equity, diversity, and inclusion and our racist systems and our power structures. When they feel comfortable and you close the door and they know you're not going to tell their physician or their nurse or their physio they do not trust us. They don't trust the system. Can you blame them? They've been stigmatized and invalidated for their entire lives. So a diagnosis is not enough. Diagnostic uncertainty is about what is the explanation for why I'm suffering from this unrelenting pain. Isabel, 17, says, I've always had anxiety surrounding my pain because I'm like, I don't know why this is happening. Why? And I think a lot of my anxiety is like when I don't know why something's happening. I know what a migraine is, but I don't know why I have them. It's not enough to go to a pain clinic and say you have migraine. I'm 16 and I can't function. This is debilitating. Tell me why, right? And pain neuroscience education doesn't work for everyone, but it does for some. Tasha, I'm looking at you just because you're from Australia. But it works for some. I've had kids who've said, what do you make of the diagnosis? And they're like, it's so cool. My brain like fires and it's blinging and blah. And they like totally buy in. And other people are like, this doesn't make sense. A 16-year-old shouldn't have this. Something's going on. Kristen says, I think if I were finally to get the right diagnosis, it would be like a huge relief because I'd know if I can be taking a medicine for it, then I can just make it stop. Let's unpack this, right? The right diagnosis. I think we need to really humble ourselves to think just because we have fancy degrees on the wall, if they don't believe it's right, if it doesn't fit with their origin story, they're not going to buy in. But here's the problem with chronic pain, right? Medicines for many, for some it works, okay? So I'm not getting on an opioid, let's not go there. Works for some, not for many. But families believe, right? If there's not a biological reason or a medicine to abolish my pain, you don't know what's going on. And think about that as a parent. Who's a parent? Imagine if your child, Jasper has a lung disease. He can take his inhaled, he can take a medicine and it helps him. So I'm okay, he's got a lung disease. But in chronic pain, there's no magic pill. But they want that, and the fact that there isn't that, and I know we're all manual therapists. Anyone? Yeah. Why are you telling me to move? There's not a medicine for this. You don't know what's going on. This is not for everyone, 40%, okay? So it's not for everyone. Haunted by something missing. And this is the unrelenting search, okay? Nicole says, she's 14, she said, it makes me kind of worried to what it might be, if it could be something really severe. But it's probably not, but still, that little inkling, if I have something in my brain that might not be good. So you can be uncertain, you can be certain, and still it's that nagging that inkling. It's torturous. This is fascinating. So I did this interview. This is James's mother. This is a 16-year-old boy with migraine. Where did it all start? She's talking about her pregnancy. When James was a little boy, he had something going on with him. They went to the pediatrician and the mom's something's not right. Anyone go to a pediatrician, they're yeah, you're fine, you're fine. That's what happened with Jasper. You're fine, you're fine. Pediatrician, yeah. And the pediatrician missed this reflux problem that caused kidney damage. The kid had to have surgery. Now that was when he was 4 years old. But when he grew up and developed migraines, that mom, you think she's going to let it go with physicians then? She said, and what if we're missing it? Because we missed his reflux when he was a baby. This is where it goes back to me with the guilt, right? We missed that reflux that caused the damage to his kidneys, so I'm always now really worried. What if we're missing something that's causing this and it's going to have long-term effects? My bottom line here is that every encounter that our patients have, even from when they can't explicitly remember their lives, right? I study memory, so you can't remember when you're a baby. If you tell me you remember you're in the crib, Jamie, I don't believe you. Okay? But all of those encounters matter. Do we ask about those? Okay. Julia says, I go see doctors, but they'd kind of just test my blood, I'd get CAT scans, and they'd say everything was fine. It was strange because we knew everything wasn't fine. Because it's not normal to get so many headaches. Do you think getting repeated tests helps people? But if your kid had debilitating migraines and you thought it was cancer, would you want some scans? This is a real conundrum. And what I love about this talk is that I can't tell you what to do. I can just pose controversial questions. And hopefully we'll have a great discussion. Searching for an alternative diagnosis, sometimes secretly, right? Because you don't want your physician to know, because you don't want to be let go. I study medical trauma in kids with complex medical conditions, and they are so afraid of being abandoned. What are they going to do? Where are they going to go, right? It's a big deal. This is Emily's mother. This shows the lengths that a parent will go to reduce uncertainty in her kid. So this mom was all for the chronic pain diagnosis, but she was willing to have her child undergo surgeries that she didn't think were going to help so that the child could just give up and accept the diagnosis and engage in treatment. She says, well, I truly hope that when she has the surgery, she'll know that everything's been done that can possibly be done. I don't want her to have a surgery. I wish she could just, but I think for her to move forward, that's her final validation. So the lengths that we'll go to, right? And this is really important. It's hard to study because physicians and clinicians don't want me to videotape what they do or say, but I do it anyway, and I have some great data to share with you. These kids are on to us, right? They don't trust the system. They're not going to tell their clinicians that they don't trust you, but when you close the door and you really ask them, Catherine, 11 years old, she says, I think they're missing stuff, or they don't know what it is. They're just trying to diagnose it, right? So how is this kid going to buy into treatment and engage? Okay. So we tried to quantify this. I'm happy to share anything you guys want. I will share with you. You don't have to go through paywalls. Like, I will give you the articles. I'll give you the questions. I love sharing. But you can ask about this in 3 simple questions. And this is from Tamar. We just adapted it for parents and kids. Have you been given a clear diagnosis for your chronic pain? Look at this. Look how many people said no. They are in a tertiary level children's hospital, one of the best in Canada, and they're saying, no one gave me a diagnosis. I don't have a diagnosis. And they're engaging in chronic pain treatment, tertiary level. Have you been given a clear explanation, right? Because diagnostic uncertainty is not just about the label. It's not enough. It's a bunch of words that mean nothing. It's about the explanation. Have you been given a clear explanation about why you have chronic pain? And I'm sorry, it's a failure if people say no, right? Like, shouldn't we explain it? Look at that. 70 to 80% of these kids, no one explained it to them. Now, they're perceiving this. I can't tell you what the physician did. They wouldn't let me videotape them. But people in UCLA did, and I'm going to share some amazing data with you. This is the key question. If you have one question to ask someone, ask them this. I think there's something else happening about my chronic pain that the doctors haven't found yet. Now, this is at the heart of diagnostic uncertainty. It's the belief that there's something more sinister causing your pain problem that the doctors haven't found out yet about, right? 30% say, yep, something else is going on. Now, these kids are in like intensive rehab, they're doing art therapy, they're seeing the social worker, the psychologist, the pool, the everything. And I guess I just really feel like if we're not even assessing this or addressing it, how the hell are they going to engage in treatment, right? So this is really cool. Alex and Abby interviewed. So these kids, or the people that you see with chronic pain, they've seen a bunch of doctors try to figure out their pain, right? Why do I have pain? Why isn't it going away? So we interviewed 16 pediatricians that often see these kids and are the first to provide a diagnosis. And we asked them, what's it like for you, physician? How do you manage uncertainty yourself? I'll never forget working in a feeding clinic, and this is a different context, but I remember my supervisor had this case of a kid who couldn't eat. Like, they were a picky eater. And so the treatment was behavioral, right? Just eat, just engage in life, this and that. And they found out years later that that child had a very significant reason for that behavior. But the same can be true for pain. What is the first sign that you have cancer? Aches and pains, right? So we asked clinicians, how do you deal with this? You're treating patients. This is really cool, I think. Anyway, the big thing was, and this is what we called the paper, where do you draw the line in the sand? How do you know when to stop ordering the tests, right? Because ordering tests can drive you crazy, right? And it was really interesting that some clinicians were like, yeah, ordering tests helps people. People believe this, right? It reassures them. And they told us that, like, sometimes they were up in the middle of the night rattled by this uncertainty. What if I miss something? They're worried too. I can't blame them. So some physicians feel like, yep, this is really relieving, it like reassures the patient, and the other ones were like, nah, this doesn't reassure them at all. And if you talk to parents and kids, they're saying they want the test, right? Because they think something's being missed, but it provides no relief, right? It's a conundrum. And I don't know what the right answer is, which is fun. I brought this up because I think it's really important, and I think it could lead to a really cool discussion. You know, when I asked you, like, do we know what causes chronic pain? And everyone's like, nope, not really. Looking for the holy grail, right? Like, looking for the gene. There's no gene. I asked Jeff Mogul. He's like, we're never going to find a gene for chronic pain. What's the pain signature in the brain and the imaging? Like, right, Tasha? It's the same as emotion and negative emotion. Like, we don't know, really. So I pose this question. I think this brave clinician is saying, let's just be honest. This clinician says, I think people often worry when they're new to this, like managing pain, unexplained pain in children. And with the new consultants, that if you demonstrate uncertainty, then you undermine a family's confidence in you. I'm the almighty physician. I know what's going on. Trust me. Trust me, little girl. I know what's going on. You got chronic pain. It's your brain. It's firing. It's pain neuroscience education. But I don't think that's the case. I think what happens is with uncertainty, I think they respond to you as a human and as a professional, and they respect your honesty. And they don't feel patronized. Power, right? I'm so fascinated by this. I just want to do this for the rest of my life. Power. And I think by that, I think they feel like it's more of a team effort. And look, I'm just going to give you my opinion. I'm not a physician. I'm not a clinician. I mean, I'm a trained clinician, but I'm not on the ground like you guys. But I fundamentally believe in authenticity and honesty. And I know, having kids myself, they sniff out our uncertainty. They sniff out our lies. And I have talked to physicians, a fabulous physician at BC Children's, Tim Oberlander, and he says, yeah, just tell him, like, we don't know. We'll never know for sure. But I know you need to function, right? This isn't working. So it's like, could you be uncertain and honest and authentic about that and still apply a functional approach? I don't know the answer to that, but I'm posing the question. That's for you guys to answer. So this data is so dreamy. Okay, I'm a nerd. Tasha, you are too. We're research nerds, and it's so fun to walk a stage again, and I'm feeling like the perks of research and academia, and we're in California. It's so great. So I presented this work. This is the last round of data, and then we're going to engage in a very lively, controversial discussion. So we knew from this work, right, that diagnostic uncertainty, even the definition, I don't believe you, physician or clinician, accurately gave me a diagnosis, and I don't believe your explanation. So it's a social phenomenon. The clinical encounter is everything. And I presented this work in Switzerland. This is just like, okay, just give me a sec. This is like the dreamiest thing ever, and I'm such a nerd about it. So I was in Switzerland presenting this, and someone said, well, what's happening in that room? What are they saying to those families? What are they saying? How are they explaining it? What are they saying? I said, I don't know. Will anyone let me videotape what they do? Because like my institution was like, there's no way. And that's interesting, right? Like, just think of yourself, like, would you allow your encounters to be videotaped? It's vulnerable, though. Thank you, Jocelyn. Yeah, cool. Well, let's collaborate. People were like totally blocking me on this, but I was like, I gotta see what's happening in the room when the kid finally winds up there. Like, what are they saying? How are they validating or not? Any DBT fans here? Dialectical behavior therapy? Validation's everything, right? Oh, God, yeah. So this woman, famous pediatrician, Lonnie Zeltzer, wrote like the first book on pain in kids. She said, I have videotapes. We videotaped families. We did in-depth interviews with the parent and the kid. These are like hour-long interviews before they wind up to the pain clinic at UCLA. This is brave. I have mad respect for her for letting me have this data. So we know where their uncertainty is at, what their origin story is, what their expectations are for that encounter. We have videotaped interactions of what happened in the room when the chronic pain physician is like giving the diagnosis, explaining it, asking the questions, validating. Oh my God, it's like dreamy. And then 6 to 12 months later, in-depth interviews. So you can see what happened, how is diagnostic uncertainty fueled, what are the physicians saying to the patient, and what are they remembering? So I'm a memory person, if you were at my talk like 2 years ago. This is fascinating because Tamar had shown that people who are uncertain, diagnostically uncertain, have memory biases. So they're not even really remembering what you said potentially in that encounter as it happened. Anyway, okay. So this is brand new data. It's not published, and I'm really excited about it. The first thing, how does that encounter shape uncertainty, right? Diagnostic uncertainty is a social phenomenon. And I'm a psychologist who is a closeted sociologist, to be honest. Like, I really believe in institutions and like the broader ecology of our worlds, media, society. This is not all in their head, uncertainty. Oh, you're just anxious. You're just, No, it's shaped by what happens in that encounter. This is Damien's mother in the pre-intake. She says, first the doctor was kind of like, nah, you don't hurt that bad. But I knew he was concerned, hanging on every word, right? I've done this as a mother. I've done this. But I knew he was concerned because he sent Damien to the neurologist the next day. So we went from one appointment to the next. So every family talked about this long, lengthy journey through the healthcare system, right? That was characterized by stigma, invalidation. I'm thinking of Keith, right? It's all in your head. And conflicting messages. The acupuncturist is telling me this, the PT is telling me this person this, and psychologically, I'm the only psychologist here, we hang on to what we want. Like, that's what we do, right? We hang on to what we want to believe, right? So it's a social phenomenon. And this is a very contradictory message. You're telling me that you're devaluing my pain, and it's not that big of a deal, and you're sending me to a neurologist for tests, right? Contradictory message. I feel so bad for these kids, and I'll never know what happened to them, and it haunts me. And I will tell you, we flew right before the San Diego Pain Summit. We flew to LA, and we were like locked up in the UCLA library watching these videotapes. And I am telling you, we were crying. You see where that clinical encounter goes wrong, and you think, and you see the abandonment. Not all the time. Sometimes it works. But it's just heart-wrenching. And you think, how is this child ever going to trust a clinician? And it's hard for you guys, right? Because you can't control what that journey was. Anyway, social phenomenon. This is a bit of a journey, and this is sort of like unparalleled qualitative research when you can follow people over time. I've never seen a qualitative paper like this. So Amber is a young child with chronic pain, and before she went to the clinic, she said, I'm scared of finding out that what I have could kill me. Her mom says, I just worry there might be something that's worse than acid reflux, like maybe cancer or something. We don't know. So very uncertain, right? Look at what the physician said at the chronic pain clinic. And they have so much expectation, right? They finally wind up in the chronic. They think that this is going to be the answer. My pain's going to go away. Physician says, there's like hundreds of tests. I'm sure that they've done like 10 specific ones, but maybe they didn't do the 11th one. Maybe it's something else. Maybe it's bacterial overgrowth. Maybe it's still a parasite. So then we'll do these other tests, which is specifically for that parasite that I'm worried about. Amber thought she was going to die, that her pain, that there was something going to kill her. And that's what the pain clinician at the Holy Grail, right? It's like the cause for the pain is like the Holy Grail. What this physician is saying, keep searching, Mom. Keep searching for infinite tests because you might find the cause. And I'm very worried. What do you think happened to Amber after? Oh, and by the way, they're told to do physio and see the psychologist and do some yoga. No. Amber's mom says, that's my main concern. That's my biggest worry, that it could be life-threatening, and they just didn't catch it. What happened to this family? What happened to Amber? Maybe worried. Language, right? Remember my memory talk? Like how we talk, our language. But don't bullshit people. Because even an 11-year-old Catherine knows if you're not sure, right? Authenticity, honesty. This is so controversial. I love it. Do you guys love this? Okay. I can't move this thing. So the question about, I'm almost done, by the way, and then we can talk. The question about where did it all start? You don't even say pain. Where did it all start? I study trauma too, so I never ask about specific, what's the worst thing that happened to you? Where did it all start? It's a great question. That elicits a person's origin story. Every family that came into this clinic had an origin story. They had a hypothesis about where the pain came from, right? And we knew this because we had these interviews. Look at Virginia before she went to the pain clinic. She says, I was walking my dog, she saw another dog, she ran towards it, and I went up in the air, just whapped down. I really went off my feet. The fall might have triggered the pain. Now, that's important. This is what Virginia believes caused her pain. You got to ask someone where it all started to get the origin story, right? The physician then listened, did a great job, okay? Listened, validated, and said, you got pulled and fell on your face. Do I think your whole pain system got turned on then? Absolutely. Not maybe. Language. Absolutely. Do I think the problem here is your brain learned really well how to have pain switch turned on and forgot how to turn it off? Absolutely. Messages of certainty. Linking your explanation, which is functional, to your origin story. And I never thought about this before I went to LA and saw these videotapes, but it makes so much sense, right? You see, and who's like, it drove me nuts when I was like training, certain like clinicians have like a spiel. Do any of you guys have a spiel? It's like, my supervisors would like explain something to every single diverse family that's different and has a different origin story in the same way. That doesn't make any sense. That's why pain neuroscience education or a one-stop algorithm will never work. Because everyone has their own origin story. And if the explanation doesn't fit with the origin story and the treatment recommendations don't make sense with that, you can't get anywhere. It's so psychological. I love it. I'm almost done. Promise. I'm trying to move it. Okay. So linking the origin story to the explanation. This is Helen's father. Before we went to the pain clinic, everybody just washed their hands of her. Abandonment. And my kids, the patient partners I work with, the kids, it's heart-wrenching how they've been abandoned by the system and what that's done to their mental health. Everybody just washed their hands of her. They said, there's nothing else we can do. That is so damaging to tell anyone there's nothing else you can do. What's nerve damage? What are you talking about nerve damage? I was thinking nerves were permanently torn or something. This is Tasha's awesome work, right? Like the language we use. Torn, damage. physical damage. So I had no idea what the hell to expect. And once the doctor, after a couple of visits, really explained what it was, yeah, I understood what was happening. Explanation. The doctor explained that the problem, what nerve damage means, is the nerves are telling Helen's brain that she's still injured. So they had to teach her nerves to tell the brain that she's healed. That made sense. Like, Richard, you were saying, like, something's out of place, or like, right? Like, all this language really matters. So this was really fabulous, right? For so many years, they thought there was a permanent problem with my kid. They're not going to get better. Damage, damage, damage. Explanation. Beautiful. So this is my second last slide. And this really resonates with me to loop back to my own lived experience. When Jasper is functioning well, when he's breathing lovely, he got COVID in January. I thought he was going to die. He didn't. He had a sniffly nose. It was amazing. When he's doing well, I totally buy into the diagnosis of his lung disease. When he's not doing well, it's shattered. And so what we need to understand is that diagnostic uncertainty is precarious and it's difficult to maintain, right? And this is the problem with pain. It doesn't always get better. And so, like, psychologists are like, yeah, but it's functional, just get back in life. And what? It's kind of nonsense. Like, do you know what I mean? That's hard to buy into. Just go to school despite the pain, the debilitating migraines. Anyone ever have a migraine? These poor kids. So when things go wrong, so you could have the most certain, beautiful, like I showed you, right? Like the perfect, like the physician did the thing and you explained it and they're buying in. If the child has a relapse or gets worse, the uncertainty gets fueled again. So this is something that we always have to kind of be considering. It's not like a one-stop trait type thing, right? So Damien's mother says, even though everything we've read said it's this, we still have, like his pediatrician a month ago said, are the pain clinics sure what it is? That's what the nurse did to me with Jasper, right? Are they sure it's this? Did they do the biopsy? Boom. Years of certainty shattered by one sentence from one random nurse. Ashley says after her intake in September, it was just like constant but exaggerated. Not that sharp, but it was like the whole area was like excruciating pain. We just wanted to make sure it wasn't anything with the bones. So I went to the orthopedist, did an x-ray, did an MRI. So yeah, it's dynamic and it's fragile, for the fragility of certainty. I'm going to end with this. It's not a high note. I love like my memory talk. I'm like, this is how you can change it and it's positive. And this is not that talk, right? This is heavy. This is hard. And it's important and it's fundamental. What are the consequences of families who are uncertain? And I gotta be honest, I was preparing for this. I was talking to Alex, who spearheaded this work. And I thought, if Jasper or Soleil or Georgia, if they wake up when they're 12 and they can't go to school and they can't move and they can't see and they're going into a spiral of depression because they've got migraines, I don't know if I could deal with that. Like, I don't know if I could go to a tertiary level chronic pain program and buy into a functional model. I'm just being honest. So the most devastating consequence is abandonment. And this is something we need to recognize, right? That in these power structures, these kids can be abandoned by the system. And this happened. Stella had 17 spinal taps before she showed up to the pain clinic. I told some of you guys that last night. 17 spinal taps. She had a pseudo-seizure, like a pseudo-tumor diagnosis, no spinal tap, these invasive kind of like surgical procedures. It never provided relief, but they kept getting the spinal tap, right? They go to the pain clinic and they're like, oh, it's just, it's migraines, it's this, like do some yoga, do some psychology, CBT. right? Trust us. We're the physicians. We know. And the mom was like, what the? What? But she has a pseudotumor. She needs a neurologist. They go back, they share that with the physician. They say, yeah, we saw a neurologist. And the physician broke up with her. I told the pain clinic doctor about that, and she got very angry that I listened to the neurologist instead of her. She just said that she wouldn't be Stella's doctor anymore. She was upset because I was taking Stella to see other doctors. I said, I can't believe you can't understand the need for Stella to have a neurologist. These are headaches. Of course she has a neurologist. She has a pseudotumor. So that conflict, we don't talk about conflict enough, right? In the clinical encounter. And my patient partner, Caitlin, she's incredible. Oh my God. I'd love for you all to meet her. She's in BC. She was abandoned. And something like this happened to her. She was abandoned by her doctor, and that spiraled her into mental health issues that she talks. And by the way, I have permission to share this. And these are pseudonyms. They're not real names. Confidentiality. This is really important, and that's very damaging, right? So, this uplifting talk, you missed the sunset. You missed the sunset. This is Alex. She is incredible. She's just such a beautiful human being, clinician, writer, thinker, conceptualizer. This is my lab. Abby Jordan is my colleague in Bath. I'm just the spokeswoman, but I just think this work is so fundamental. And we have power in how we listen and how we validate. And that's the one thing I can say. Validation and the need for validation and listening was a thread through all of this. So I think there is a rosy ending, maybe in a couple of years when I have more data, but I'm just not there yet. So I hope I've posed some questions that get you kind of interested, curious, reflective, but I don't have the answers. And with that, thank you.
Oh, we got some questions for you. And thank you. Like, it doesn't have to all be rosy.
Yeah.
Because then you're that person saying everything's fine.
Life is hard.
Life is hard. I like that. Okay, so this is from Deborah. Thoughts on framing this in terms of social community theories related to eliciting an observer's motivation to want to provide care in service to survival. Diagnostic uncertainty challenges the human need of knowing they are in good standing with a group or community to ensure survival. The idea that one needs to prove that there is no social deceit that a valid diagnosis offers, because if not deemed to be in good standing with the group or society, they will be deemed worthy of care, driven by the biological worry of excommunication.
Is that a question?
Just
That's
thoughts.
beautiful.
Yeah, that's Deborah.
It's Deborah.
Yeah.
Do you want to talk about it? That is like beautiful and heavy and thought-provoking. I'm just curious.
Hold on. So people at home can hear.
You can come up too if you want.
I don't need to. I'll stand up though. So kind of stemming from my own investigations into shame and stigma work, and that it signals to the person who's experiencing the shame that the social communication signals to the person who is feeling the shame that the observer has judged something as less than, not worthy, right? Social deceit, right? And so we're driven to want to stay in good standing within our group for survival, like biologic survival over the last, many thousands of years. And that if I don't have a valid diagnosis that confirms that I'm not cheating, right, will that change the motivation of the observer and their drive to want to help me? Does that make sense?
Yeah.
That's all I hear is this is all about social communication, right? And what is the purpose of expressing a need state? The purpose is to elicit care, right? And if I can't have a valid diagnosis that's believable,
Yes.
why would anyone want to help me?
Right.
Right?
And so in that paper Tamara wrote, Chasing the Ghosts, it's a beautiful paper. I'm happy to share it with people. She talks about that, like the guilt that evokes in the person. And that to me at first was like, what? Why would you feel guilty? But they feel guilty that there's not, like they take that on themselves, that there's not like a valid, legitimized reason for the pain. And they experience the stigma and they attribute that to being their fault, right? It's kind of heartbreaking, isn't it? So yeah, I think it is all a transaction, and that's what's gotten me more and more interested in the power relationship, right? Because it's not just the observer, and like there's a lot of power there, right? So then how does that sort of play into that transaction? It's a transaction, right?
Well, and part of the power is the gatekeeping of care.
Yes.
Right? And I mean, all of that, right? So if within providers, part of our own identity is I'm a good clinician.
Yeah.
I figure out the patterns. I help people get better.
Yeah.
And if I can't knowingly feel confidence that I can help this person,
Yeah.
am I going to be less driven to want to help them?
Like learned helplessness.
Well, just it challenges my identity.
Yeah.
Right? I'm an expert. I know how to help people.
Yeah.
And if I'm confronted with a patient that challenges
Right.
that identity for myself,
Yeah.
might I want to distance from them? Right? Kind of creating more distance in those relationships in the clinic.
Wow. Do you want to write a paper like
Actu-
that?
That is. Yeah, I'm actively doing that actually.
That is really.
Sarah's read a version.
I know, and I realized sitting here listening, I'm like, I think I have another version to read, but that was in my personal email that I need to get to. But yeah,
Yeah.
it's
Yeah, please.
what the
Let's
fireside
do it around
chat
the
is
fire
for.
pit tonight. No, but that's really. I think that's why I really liked like interviewing those clinicians, right? Like this is hard for them. It's antithetical to sort of like it's contrary to their medical training too, right? And it's uncomfortable. And ultimately, you'll never know definitively, will you, if something was missed? How will you ever know? I listened to a podcast a couple weeks ago. It's this woman who got diagnosed with cancer, like stage 4 cancer. She was like 34 and she had like a young kid. And her pain was dismissed and over, if someone had taken a functional approach to her pain, she would have died, right? This is really hard stuff. And I don't envy being in that position to make that call and to draw that line in the sand. Yeah, cool. Yeah, I want to talk to you.
So to be continued at the fire pit.
Yes, yes.
Awesome. So